Our first topic will be about the multidisciplinary team approach to brain and spine tumors. We're a long-standing multidisciplinary team. It was established, as Dr. Mike said, in 2008. And it's one component, the Brain and Spine Tumor Center is one component of the Brain and Spine Tumor Center. Since our establishment, we've been a very staunch advocate of the multidisciplinary team approach. The Brain and Spine Tumor Center has, over the years, held symposia promoting the MDT, or the multidisciplinary team approach, in Metro Manila, in places like Davao, in Clark, Baguio, Subic, Bacolod, and other parts of the country, aside from Metro Manila. Last year, the different centers of the Brain and Spine Institute had a combined meeting with experts from all over the world. Now, this is a snapshot of our Brain and Spine tumor team at one of our meetings. This is obviously pre-pandemic, as nobody is wearing masks and there's no social distancing. Today, our meetings are held on Zoom. So we are a group of healthcare professionals of different disciplines who work together to uncover the best possible solutions for our patients who have complex medical conditions, since we're dealing mostly with cancer and brain tumors. The team's strength lies in our ability to commit more knowledge and experience to a problem than any single member can do, acting alone. So I guess the first question is why? Why do we need a whole group of people to take care of just one patient? Magusot at pinsang masalimuot ang paggamot ng mga cancer o bukol sa utak at gulugod. And this is just a short list of possible healthcare professionals that might be required to help a patient. There is truly potential for miscommunication, poor coordination, and even misunderstanding. It's like basketball, parang basketball siya. You can have stars, you can even have superstars on a team. But often, it's a team that works together, that displays teamwork, and makes proper use of the talents of each of its players that often wins the day. So what is this multidisciplinary process? It happens in 3 stages. Nauna ang pagkonsulta ng isang pasyente sa kanyang manggagamot or attending physician. The physician will discuss the diagnosis and stage of the disease, and they will talk about the possible cures or possible remedies. Also discussed will be the viewpoint of the patient and the patient's family. Yung pangalawang hakban, or the second step, is the multidisciplinary conference itself. The attending doctor presents the case to the team, and our team, who has specialists in neuroradiology, neurology, both adult and pediatric, oncology, both adult and pediatric, radiation oncology, neurosurgery, and neurosurgeons of different specialties. We have spine surgeons, surgeons like myself who do a lot of radiosurgery, surgeons who do open surgery, who do open awake surgery. So we have a whole, and we even have skull-based surgeons. So it's a whole gamut of specialties in neurosurgery. Of course, we have a neuropathologist and other specialists. The members discuss diagnostic and therapeutic possibilities from their unique viewpoints. And the patient's views and preferences are always considered when recommendations are made. The process finishes with the third step, which is feedback to the patient. So this is another meeting between the attending physician and the patient. And they talk about the conference and what the recommendations at the conference are. And hopefully, armed with data and the team recommendations, the patient and the family can come to an informed decision of what they think is best for the patient. This is a quick summary of those 3 steps. Our objective is for comprehensive care. We have to remember that when we consider brain and spine tumors, treatment can come in the form of operative surgery, maybe gamma knife radiosurgery, radiotherapy, chemotherapy, immunotherapy and precision oncology. Or it could be a combination of all of these. At ang pagtitiempo nito ay maaring papalit-palit at paiba-iba batay sa mga pangangailangan ng mga pasyente. Now, treatment is not the only objective. Our treatment also monitors progress, discusses biopsy findings, which affects how we have to evaluate response. We also treat complications of treatment and consider palliative options for patients who have severe disease or advanced disease. How does the patient benefit? Well, it does shorten time from diagnosis to treatment. You can think of it as one thing when a patient is presented, then all the specialists know about the case since we've talked about the case. And so it's easy for us to get from diagnosis to treatment much more quickly. There's a greater likelihood of receiving consistent and timely care, and patient care is managed by a team. And this increases patient satisfaction with the care. In the end, we want to provide the best possible care for our patients who are afflicted with tumors of the brain and spine. Let me segue to the oldest multidisciplinary team in the Brain and Spine Institute. This is the Gamma Knife Center, or the Philippine Gamma Knife Center. So these are the questions which I hope to be able to answer with this portion of the talk. What is gamma knife radiosurgery? How is it done? What are its applications? What are the benefits and risks? How does it compare to open brain surgery? And where can gamma knife radiosurgery be done? Gamma knife radiosurgery. Minsan po itinatawag itong SRS or radiosurgery. Was invented by this fellow here, a Swedish neurosurgeon named Lars Leksell. Talking about him and how this developed, stereotactic radiosurgery developed to be a long lecture in itself. But suffice to say that as a young neurosurgeon in the 1930s, he was bothered by how high the risk was for undergoing brain surgery. At that time, in the 30s, 3 out of 10 patients would probably not survive the surgery. And he sought to reduce the hazards of open brain surgery by delivering maybe a high dose of radiation. This was not radiotherapy. He used a very high dose of radiation to destroy any deep structure without risk of bleeding or infection. And in the 1950s, you see in this picture here, was the first version of the gamma knife, which found clinical use in Sweden. Now, he achieved this high dose by focusing, for lack of a better term, many small beams of radiation into a small defined volume. Now, stereotactic radiosurgery has evolved since then. And in this very long definition, I'd just like to emphasize here in red that it is a multidisciplinary team consisting of a neurosurgeon who leads the team, a radiation oncologist, and a medical physicist that manages the procedure. Now, this is a picture of the team with the late Dr. Eduardo Mercado. And this is our state-of-the-art gamma knife, the Gamma Knife Perfection. So, how is gamma knife radiosurgery performed? How is it done? The workflow is actually just in 4 steps. Now, first, we attach a stereotactic frame to a patient's head. The frame serves as the landmark by which we base all our measurements. The second part, the patient undergoes digital imaging, and this can be in the form of an MRI scan, a CT scan, or digital angiography, or a combination of these, depending on what the patient's problem is. We then program the machine for our target, whether it's a tumor or vascular malformation or a functional target. And finally, once the programming is set and transferred to the machine, the patient is treated. We set up the patient in the gamma knife. The treatment bed is robotic, so after we set him up, the machine just follows our program and goes through with the treatment. The actual procedure is actually painless. This slide summarizes the broad applications of gamma knife radiosurgery. We can treat tumors, both benign and malignant. There are certain vascular diseases of the brain that we treat, and there are functional indications like pain from trigeminal neuralgia. Gamma knife to treat movement disorders, obsessive compulsive disease, and some forms of epilepsy are being performed in other centers abroad. But today, we're just going to be talking about the tumors, the benign and malignant tumors, and just a small subset of these. So, since we started in 1998, we've had performed over 3,000 cases already, and almost 700 of these are vascular, close to 2,000 are benign, and nearly about 500 of these are malignant tumors. Now, talakayin muna natin ang dalawang pinakamadalas na nakikitang benign tumors. Now, what are benign tumors? Benign tumors do not spread, but they have a tendency to enlarge and cause damage. The two most common are meningiomas, which we will be talking about first, and vestibular or otherwise called acoustic schwannomas. So, meningiomas are tumors that arise from the tissue covering the surface of the brain and the spine. They're often benign, but rarely there are some aggressive variants. Now, these tumors can be found either close to the surface, as seen here, or nestled deep within the skull. Now, this is an example of a deep meningioma. This is what we describe as a petroclival, because it's in the petrous bone and close to the clivus. And the picture on the right here is the treatment after gamma knife after 6 months. This is another deep meningioma. And we can see here on top the treatment day, followed by 1 year and 3 years after. The goal or the objective of gamma knife radiosurgery is to control or stop the growth of a tumor. Over time, some tumors may even get smaller. We have treated close to 900 patients with meningiomas at our center, and this is our usual dose here. And we've achieved close to a 95% control rate that we've recorded. Now, the image on the right shows a meningioma closer to the surface of the brain, at which we've been observing for over 4 years now. And we can see it's slightly smaller at the 4th year. From meningiomas, we can move on to another very common benign tumor, the vestibular schwannoma. These tumors arise from the 8th nerve, or the nerve that conducts impulses for hearing and for balance. These tumors are also generally benign. This is a patient with a small schwannoma treated and followed over an 8-year period. So you can see here treatment, 4 years and 8 years after. This is a slightly larger tumor, maybe not slightly, but a larger tumor at gamma knife treatment, and at 5 years later. And then we can see how the tumor has shrunk after treatment. Now, we have done a little over 400 cases of vestibular schwannomas. Our tumor control rate is about 95%, give or take, and the rate of cranial nerve complications is low. The image on the right shows a patient which we followed for over 4 years now. So at treatment, this is, I think, 2 years and 4 years after. Now, the second group of tumors we will cover are the malignant tumors. These are more common. The most common of these are the brain metastases. And of this kind of tumor, we've done over 350 cases. Now, a brain metastasis is a cancer that spread to the brain from a primary or original site. This happens in about maybe 17 to 20% of cancers. Some will report slightly higher. They're more common in lung cancer, in breast cancer, and a form of skin cancer called melanoma, though in Filipinos, this is a little less common. Cancers from the kidney and the gut have been also observed to metastasize to the brain. Now, unlike benign brain tumors, metastasis can be complex to manage. You have to consider the source or the primary tumor. You also have to consider sites of spread or the secondary sites, like the skeleton, the liver, the lungs. And as far as the brain is concerned, what's the most appropriate kind of treatment, all things considered? Would surgery be the most optional treatment, optimal treatment? Would whole brain radiation be a treatment? Or would gamma knife radiosurgery be the treatment of choice? This is where a team is truly required and appreciated. At the Gamma Knife Center, we have about an 85% control of solitary or single metastases. These pictures below are of metastasis from a patient with brain cancer, roughly 1 year apart. Our control will drop to about 80% when we deal with multiple metastases. If we talk about survival, that is affected by many factors, not the least of which is the nature and the status of the primary disease. For solitary lesions or single lesions, we can offer gamma knife radiosurgery if the target is smaller than 3.5 centimeters in diameter, and if the primary is known. For multiple metastases, the number of lesions is not as important as the aggregate volume of the lesions. Usually we look at maybe 15 and to 20 cubic centimeters tops. For a patient undergoing surgery, we usually will recommend focal treatment of the tumor bed to prevent recurrence. This is a picture of a vestibular schwannoma we've now been following for over 10 years now. And this is a very good result. You see here from treatment and yearly after that, you see shrinkage and finally at this point, static, the tumor stopped growing. But there are situations where radiosurgery might be limited or may not be the best option. One limitation of radiosurgery is we don't have a biopsy, we have no histopathology. So if a lesion, especially if the lesion presents in an unusual way, either by having an unusual history, so a lesion that might look benign but has a very fast history, or have an unusual physical exam or strange looking imaging, we may often suggest either a surgical option to either remove the lesion or take a biopsy of the lesion. We, as a rule, do not treat large targets like this with single session radiosurgery. For lesions like this, where you have brain compression, extensive brain compression, we usually will say that surgery would be a better solution for this issue. Finally, we have to be able to deliver an effective dose of radiation. And there are some structures in the brain that will not tolerate radiation well. And these include the brainstem and the optical nerves. And so if the target is too close to these, like this, radiosurgical procedures may not be feasible. Now, to wrap up this talk, these are the advantages of gamma knife radiosurgery. It is cost effective. When we tell you it will cost so much, it will really just cost so much because you won't end up with an extended stay in the hospital. It affords a good quality of life. It allows maintenance of functional status. It allows treatment of lesions usually not amenable to surgery. And it allows excellent control with minimal morbidity. This can also preclude delays in chemotherapies for patients with tumors of the brain, who require chemotherapy. If we do a gamma knife procedure, you can finish it in 1 day and proceed with other treatments that are necessary. Now, often these gamma knife procedures are performed on an outpatient basis. So this small graphic below shows a sort of a comparison between gamma knife and open surgery. So from symptoms to diagnosis, if you have open surgery, after surgery, will probably stay a couple of days in the ICU and maybe a couple more days, maybe a week or 2 in the hospital recovering, and maybe another month and a half convalescing at home. If you do a gamma knife radiosurgical procedure, you can actually go back to work the next day or the day after. The final question is, where can gamma knife radiosurgery be done? Now, the gamma knife is the gold standard upon which other radiosurgery machines are measured. And I have to emphasize, there's only one gamma knife in the Philippines, and it's here at Cardinal Santos Medical Center. But more importantly, the gamma knife is a tool. And more than looking at the tool, you have to think about the people who use the tool. Our multidisciplinary team has over 24 years of experience, of know-how, and has experience with over 3,000 cases and probably more than 4,000 procedures. So this is the place to take them for radiosurgery. I'd like to thank you for your time and your listening.